All right, I think we have the webinar up and running. Um, so welcome everybody. Hi, I'm Joanne Spetz. I'm the director of the Institute for Health Policy Studies. This is our monthly grand rounds, and we are delighted to have Katrina Kimport here. But before I introduce her, I want to acknowledge the Ramaytush Ohlone people, who are the traditional custodians of the land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And those of you who have been affiliated with IHPS for a little while know that we are big champions of UCSF's Native American Health Alliance and other activities in this space, as we know that our founder, Phil Lee, was a champion of Native American health and improving health of all people worldwide. So I am delighted to introduce Katrina Kimport today. She is our Grand Round speaker talking about the impact of abortion bans in the United States. She has a deep expertise in this area and is a professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences, and is a sociologist in ANSWER, which is the Advancing New Standards in Reproductive Health. We have a number of affiliates and relationships with ANSWER. Her research looks at the issues around reproductive health and inequality in health and reproduction, focusing on abortion, contraception, and pregnancy. And I've had the pleasure of getting to know her through our shared affiliation with the Health Force Center at UCSF as well. So I'm going to let her take it away. I will note that if you're on Zoom, you can put questions into the Q&A box that is in the webinar. And the Q&A is going to be moderated by Sarah Garrett, who is on the core faculty here, because I have a class that I teach at 1 o'clock. So I'm going to be slipping out of the room towards the tail end of the Q&A. So I'm going to let Sarah take that over. So take it away.
Hi, everyone. Thank you so much for that lovely introduction. And thank you, everybody who is here today and on Zoom. I can't see you, but I believe that you are there. So I'm going to be talking about what I've titled the long tail of abortion bans. I have nothing to disclose. I want to acknowledge some funder support. So I want to start with a little bit of background about abortion in the United States. And I'm sure mostly this won't be new to folks who've paid a little bit of attention to the news, but I want to zero in specifically on what's happened in the last few years. So there have been some pretty dramatic changes to abortion legality in the US. So this started really in the beginning of September 2021, when Texas was able to put into force the Senate Bill 8, known as SB 8. And it did two things that were different than restrictions on abortion had done prior. The first one is that it restricted abortion after cardiac activity was detectable, which is typically around 6 weeks gestation. This is much earlier than any state had attempted to restrict abortion in the past. And second, its enforcement mechanism was this novel sort of bounty hunter law. What that really did was signal to people who were engaged in abortion care, abortion advocacy, that once the Supreme Court allowed SB 8 to go into effect, that Roe v. Wade was probably on its last legs. And indeed, in June of the following year, not even 1 year after SB 8 went into effect, in the Dobbs versus Jackson Women's Health Organization Supreme Court decision, Roe was overturned. So the precedent that had been in place since 1973 that protected established a federal right to abortion until viability, we'll talk about that in a little bit in a moment, was now overturned. And states were free to legislate around abortion however they wanted. And they quickly did. So within 3 months, there were new or newly enforced restrictions in 18 states. There were some states that had laws on the books that were decades or even a century old, restricting abortion, that were moot under Roe. However, once Roe was overturned, they went back into effect. There were also laws that states in anticipation of Roe being overturned had put into place. These were known as trigger bans. And then there were states that jumped right in and passed new legislation following Dobbs to restrict abortion. This is what we're looking at right now. And I want to note my deep appreciation to KFF for making such beautiful maps. So this is as of September of this year. The states that are flagged in red, it's a little bit small. So the ones that are in red, those are states, that's 12 states where abortion is entirely banned. There is no point in pregnancy when abortion is legal. There are another 6 states that are sort of the dark orange. These are states that have a ban that's between 6 and 12 weeks after the pregnant person's last menstrual period. And then there are an additional 4 states, sort of the lighter orange, which have a ban between 18 and 22 weeks after the last menstrual period. All of these laws would not have been enforceable under Roe. So with that overview, I want to talk a little bit about what's new and what's not so new about these restrictive laws. So let's start with what's not new. It's not new that laws restricting abortion focus on pregnancy duration. So before Dobbs, under Roe, most states, including California, banned abortion after a particular point in pregnancy. In California and the additional states that are currently on this slide highlighted in blue, these are all states that have a limit on abortion based on this amorphous concept of fetal viability, right? This is a fetal development, the point in fetal development. And my colleague Tracy Wheats and I have written about the sort of difficulty of using this as a model for establishing when care is available or not. But these are laws that have been on the books for decades. And even in California, so some of you may remember in 2024, we passed Proposition 1, known as the Constitutional Right to Reproductive Freedom Amendment, that ostensibly should have eliminated most of these impediments to abortion access. However, the viability law remains on the books, and most people interpret that as meaning that it's still in effect. What this really is telling us is that this idea of abortion care being limited at some point in pregnancy is not new. So these post-Dobbs restrictive laws are new really only in the point at which pregnancy they've decided to limit care, not the idea that it is acceptable to limit care not based on skill or safety, but rather in some sort of social reasoning, whether that's a moral or religious, or this idea that sort of the state has an interest in fetal life, which is what the Supreme Court has used in their phrasing. Okay, so what is new about these post-Dobbs restrictions? There are 2 really big things that these post-Dobbs restrictions do differently from laws that existed before Dobbs. For one, they classify violation of these laws as a felony, and it comes with serious penalties. So up here are flagged. So these are the 12 states with total abortion bans. And in 11 out of 12 of those, there are criminal penalties for physicians convicted of violating the abortion ban that include jail time. And this ranges from 2 years to life. So for one violation of an abortion ban, that is life in prison. 7 of these 12 states also require that physicians convicted of violating their state's abortion ban, they have to pay a fine. In Idaho, this fine is not less than $1,000. In Texas, it is not less than $100,000. And in addition, in some of these states, the violation of the abortion ban or conviction of a felony is grounds to lose your medical license. So to put it simply, these bans, unlike restrictions that happened prior to Dobbs, come with really serious criminal and professional penalties. The second major difference in post-Dobbs restrictive laws is that they don't allow for physician discretion. So this is a different way of saying they don't include language that functionally establishes exceptions to these bans. Sometimes these are called medical exceptions, life exceptions, health exceptions, fetal health exceptions. So the map that we're looking at here is a little bit out of date, is as of December of 2023. My deep appreciation again to KFF for their beautiful maps. But it's still, for our purposes, I think can be useful. So here, what we're seeing is these are the states, the 20 states that have total abortion bans or early gestation limits. These are the ones that have an exception. All of them, in fact, have an exception that's known as a life exception to prevent the death or, quote, preserve the life of the pregnant person. How it's operationalized, however, is vague, right? And I'll talk more about this in a moment. One of the other new things in terms of these bans is related to this idea of health exceptions. So among the 20 states with a total abortion ban or early gestational limit, as of December 2023, 5 had no health exception. So despite any potential very, very serious or reversible harm of continuing a pregnancy in those 5 states, there was no opportunity for an intervention that would end the pregnancy. And even in those states that do have a health exception, it's important to note that this is not written in clinically recognizable language, right? They make basically operationalization of when somebody has met a health exception difficult or even impossible to establish. And finally, one of the things that most state bans did, not all prior to Dobbs, but most state bans, and again, these were happening at a later point in pregnancy, most had exceptions for fatal fetal anomalies. However, that is not the case in these post-Dobbs bans. So these are situations where it is known that the fetus will die either before birth or shortly after. There is inevitable fetal or neonate death. And in the post-Dobbs restrictive laws, 13 have no exceptions for a fatal fetal anomaly. The person who is pregnant is required to carry the pregnancy, which is a fetal pregnancy. Okay. So what do we know about the effect of these abortion bans? And when I say abortion bans, I'm sort of going to the lowest common denominator. I don't know if I use that phrase right. I'm mostly qualitative. But this idea that I am looping in a little bit some of the states that have these early gestational bans, although primarily I am focused on ones with a total abortion ban, because it turns out there are a lot of them and a lot of people live in those states. So there is a lot going on. Okay, so what's the effect of these new post-Dobbs restrictive laws? Well, let's start with their impact on abortions. It seems like a reasonable place to start, right? These are intended to eliminate abortion. Well, it turns out the total number of abortions have actually increased since Dobbs, despite the bans. So this research comes from the Society of Family Planning's We Count project, which is co-led by my Answer colleague, Ushma Upadhyay. They've been tracking abortions on a monthly basis in the US since April 2022. And as you can see in this slide, you can see the trend that goes through the end of 2024. Recent data is consistent with this pattern. There is a bit of a dip in the few months following Dobbs, but then actually it goes back up. And we are at now a higher total abortion volume than the measured rates that were happening before Dobbs. Now, there are a few factors that are thought to contribute to this phenomenon. And among them is the implementation of telehealth and provider shield laws, which are now in effect in 8 states, including California. Shield laws enable physicians offering telehealth to provide care according to the laws of the state they are in, not the state that the patient is located. So what it means is that in practice, a shield law provider, say in Massachusetts, can provide medication abortion to a patient who is located in Texas. And this is something that there is, various litigation involved in. Which will be interesting to watch. And in the meantime, that is contributing significantly to access to abortion despite these laws. In addition to what we see here, there are some additional uncounted abortions. So there has been a rise in, well, I guess we don't know exactly that there's been a rise because it wasn't something tracked before, but an idea of community providers. So these are people who will share medication abortion pills outside of the formal healthcare system within their communities. You may have seen news articles about people who are, bringing pills across the border from Mexico into the United States for distribution. There's also a number of ways people, especially through like the Plan C website, people can get connected to pharmacies overseas where they can direct order medication abortion for delivery to their homes. These are abortions that are uncounted. So even as we see this total abortion volume up, it may even be higher than this in practice. So to the extent we don't see an impact on abortion or abortion volume, at least, where do we see some of the impacts of these bans? And one place that an emerging literature has really focused on is on obstetrics. So there is an emerging literature that's identified ways in which these bans and early gestational limits have contributed to delayed and denied care in obstetric settings and to patients having to become sicker before they can receive care. A lot of the reason they're becoming sicker is because physicians and hospital systems need to comply with that vague language of the law, right? Like it's not clear, how do you operationalize when somebody's life is at risk? How do you operationalize when somebody is at risk of irreversible harm to a major bodily system, as some of the laws have articulated the health exception? So with colleagues at Answer, I'm part of a study called the CarePost Row study. And we launched this soon after Dobbs, and we solicited anonymous narratives from clinicians who had participated in care for a patient whose care deviated from the standard because of post-ops restrictions. And we got just an avalanche of responses very quickly. These were anonymous narratives that clinicians submitted. And we've produced 2 reports on our findings, that QR code, handy QR code, if you want to see the whole report. When we looked through these narratives, these are some of the scenarios that clinicians reported. So to flag them, this first category, these are obstetric complications in the 2nd trimester. This is prior to fetal viability. Fetal viability itself, as I've sort of alluded to, is an ambiguous point. It is not some sort of clear-cut point. There are a lot of factors that contribute to whether or not a fetus is viable. But basically, during the 2nd trimester, there is not a way for a pregnancy to end through a live birth, right? It's just not possible. And there are things that can happen during the 2nd trimester, including one that I'll be talking about in a few examples a little bit later, known as PPROM. And this is a pre-viable, preterm, pre-labor rupture of membranes. Basically, the amniotic fluid leaves, and so there's not a way for the fetus to continue to develop. There's also a high risk of a life-threatening infection, and that's an infection that can come extremely quickly for the pregnant person if the pregnancy continues. Other examples up here that I'll offer some cases of in a moment, things related to ectopic pregnancy. These are pregnancies where implantation has taken place outside of the uterus. So for example, in the fallopian tube, this can never be a viable pregnancy, and if allowed to continue, will lead to a rupture of the fallopian tube, which can cause internal bleeding, hemorrhage, and death. Other scenarios that clinicians flagged were situations related to other conditions that complicated access to care, fetal anomalies, as I've noted. These states don't have exceptions, most of them, for a fatal fetal anomaly. There are also issues with receiving timely miscarriage care, which are ways in which it's really illustrated that you can't separate out abortion care from reproductive health care broadly. So despite this idea that it's something that can sort of be identified and segmented out, it is a fundamental part of comprehensive reproductive health care. So I want to offer 2 examples from the CarePost Row study to illustrate sort of how and why care is denied or delayed under these post-ops restrictions. So these are drawing on, after the anonymous narrative submission, anybody who submitted was invited, if they were interested, to participate in an in-depth interview. And so both of these cases are drawn, these quotes are drawn from those interviews. So first I'm going to offer a case of denial to sort of illustrate how somebody ended up being denied under these laws. So there was a family medicine doctor who described a patient who had a severe pre-existing heart condition. So as the doctor explained, the chances of her dying in childbirth were extremely high because her heart would not be able to handle the additional load of pregnancy. But based on their understanding of the state's total abortion ban, the healthcare team felt that they could not care for her. An abortion at this time could not be justified, even though she was inevitably going to have an emergency. She was not currently experiencing a health emergency. But when in the future she would be at risk of dying was unknown. And so they just simply couldn't justify an abortion. So as the doctor said, she wasn't actively dying now, but she would be at extremely high risk of death several months into the future. So the clinicians in this case who were involved in her care were told by their hospital that it was illegal for them to provide her with an abortion. She ended up traveling out of state in order to end her pregnancy and save her life. As an example of how care is delayed, this was a case from an OBGYN hospitalist who described a patient with PPROM. That's what I was talking about, the pre-labor, I can't even remember all the letters, rupture of membranes. And this was at 16 weeks gestation. So even if there is, with high levels of NICU access and, highly specialized caregivers, that maybe some percentage of babies born at 22 weeks can survive. 16 weeks is very far from 22 weeks. And so she presented for care, but she was denied twice. So how this was described by the hospitalist was there was some hesitation on the other physician's part that she didn't have a white blood cell count at the time and that she wasn't necessarily sick enough to consider it life-threatening. 2 days later, so she was turned away and then she kept coming back 2 days later. She had a fever of 105, a white count of 1, heart rate in the 160s, and a blood pressure that required pressors. Now, I'm not a clinician, but this sounds bad. In fact, as the interviewee described it, she was trying to die. So at this point, she was sick enough to be offered an abortion based on their interpretation of the law. But while this serious outcome was predictable, exactly when it would become life-threatening. So this is like a shorter timeline than the first case that I offered, but it's still unknown within that. And PPROM in particular can turn very, very quickly. In the end, because they delayed the interventions until the situation became as they could feel secure in claiming it to be life-threatening, the patient came close to dying, required a multi-day stay in the ICU, and nearly required a hysterectomy. So it's clear from this emerging literature documenting clinicians' experiences that these post-ops restrictive laws negatively impact patient care. And as these investigations continue and the shifts in obstetrical care are further documented, the questions of how patients experience delayed and denied care becomes even more crucial to understand. So that's what I'm going to turn to now with a new project that I've been working on. And I'm actually, for the purposes of our conversation today, going to zero in on an even more specific question. And this is one that can't be answered by clinicians. What happens after the pregnancy ends by whatever means? So that may be an intervention in the form of abortion care. And it actually, for some people that I interviewed in the project I'm about to describe, that meant continuing the pregnancy until they went into labor on their own. What happens after that when the patients go back to their lives? So we know that patients have to get sicker, that they have to be pregnant longer. What we don't know is what, if any, consequences do the patients experience well after the fact of these delays and denials. And then we hit our first challenge. How do you find people who received some substandard care and know it? My colleague Lori Friedman has found in her research of Catholic healthcare, and Catholic healthcare is governed by a set of directives that limit what care can be offered within their setting, and frequently requires then care to not meet the standard of care, particularly around reproductive health care. Patients don't always know when they're not getting the standard of care. So how are you going to find those patients, right? The clinicians, they know, and they come forward, and they also are doing their best to create workarounds to care for these patients. And so, patients may or may not always know. So I was able to resolve this challenge through 2 recruitment pathways to find patients who've been negatively affected by post-ops restrictions. So the first pathway is I partnered with advocacy organizations. And so these advocacy organizations were in touch with a number of patients who had had their care negatively affected by these abortion bans. In some cases, people reached out to the advocacy organizations. They were hoping for support, for resources to help them, fight and make public the issues that they had experienced. And in addition, some of these organizations actually had very extensive media coverage tracking. And so they would then reach out to anybody who had shared their stories, including anonymously shared their stories. And these organizations were generous enough to share my invitation to participate in this study with some of the patients they were connected with. In addition, as part of a project being led by my Answer colleagues, Diana Green Foster and Nancy Berglass, this is the End of Row study, which was launched soon after Dobbs fell. Actually, it launched a little bit before in order to do a comparison. It has over 1,700 participants enrolled who are completing regular surveys for over a 2-year period. And really trying to examine the consequences of what happens with the fall of Roe. As part of their intake surveys, they report whether or not there was a fetal or a personal health issue that was related to their interest in abortion. And so for among those who said they were willing to participate in future research, I've reached out and interviewed them as well. And what that's meant is, this is, late breaking 50 semi-structured patient interviews and conducted between January of this year and last Friday. That's thus the last minute update. They've averaged about an hour and a half. And the people that I've interviewed were in 10 different states at the time of their pregnancy. All of these states had new post-Dobbs abortion restrictions. Also, it's worth me mentioning that 7 of these interviewees actually had 2 pregnancies that were affected by the restrictions by the time of the interview. And these occurrences took place between June 2022. So this is, right when Dobbs went into effect, and as recently as July of 2025. They occurred for the person who was pregnant. They were anywhere between 8 weeks into their pregnancy and 32 weeks. 32 of these pregnancies, now we're getting a little bit into our unit of analysis confusion. So because some people had more than one pregnancy. So 32 had an indication of a fetal health issue. Sorry, do I have my number? No, 33. 22 had an indication of a maternal health issue. So this was something that was going wrong with their own physical health, and 3 actually had both for the same pregnancy. To give a little bit more characteristics of the people I interviewed, they ranged in age from 22 to 45. These are not the ages at which they had the pregnancy. But that's where they were when I interviewed them. Most of them identified as white. Most of them had a high educational attainment. And then most of them either had no children at the time of the first pregnancy affected, or one child. And then 22 had a baby between that the first incident, for those who had more than one, and the time of the interview. Most had received prenatal care, but not all. And 19 were able to ultimately receive care for their pregnancy in their state, and 37 had to travel to a different state in order to receive care. All of these women survived, which excellent reporting by ProPublica has shown is not always the case. There are documented instances where the delays and denials of care have resulted in pregnant women dying. For the people I interviewed, their care experiences were often harrowing. They included sometimes urgent travel to unfamiliar places, notably places where they then received compassionate care. They included fear for their own health, experiences of hemorrhage, ruptured fallopian tubes, even sepsis. Layered onto this, sometimes this meant worry that they could potentially get their partners, their family members in trouble for helping them in any way to obtain an abortion. I mentioned earlier that there's language in some of these bans around a sort of bounty hunter phenomenon. All of them received clinical care that stabilized them and saved their lives. Though it's worth emphasizing that medically speaking, the risks to their lives were known well before they became emergencies and could have been avoided or significantly reduced with earlier interventions. Once the pregnancy health complications were resolved, they were left with a number of ongoing effects of their experiences. And that's what I want to then talk about in the last several minutes of my talk. And I'm going to talk specifically about 3 ways that interviewees experienced long-lasting effects of their delayed and denied care. So I'm going to start first with ongoing physical health difficulties. Sorry, we're not going to, I guess my animation did not go through as intended. So I'm going to talk about first a case of a woman who had PPROM at 16 weeks. So about a third of the women that I interviewed described a physical health challenge that lasted more than 1 month after they were discharged from care. So this is not the sort of standard expectation of recovery after ending a pregnancy, that these were effects that were more substantial than would be considered normal. So this woman who was a 34-year-old Black woman, had PPROM at 16 weeks. She was not able to end the pregnancy until 5 days after her membranes ruptured. Then she was discharged. She continued to have serious pain and swelling. More than a week later, she was admitted to the emergency room, and she was septic, meaning she had a very serious infection. She had substantial fluid in her abdomen, a partial lung collapse, and fluid in her colon. She was in the hospital for 3 weeks and had multiple surgeries. When she was discharged, she said, "I wasn't able to stay at my home because I needed around-the-clock care. I couldn't shower on my own." I think that's supposed to be, I couldn't shower until April. And that was in January. Okay, so this is multiple months of basically being unable to care for herself. So she ended up moving to live with her parents because of her husband's work didn't allow him to be able to be present all the time for her. And so she was then away from her home, her husband, her community. She was really happy to be with her parents, but still this was really distressing. And this is, I'm talking to her 2 years later, and she talked about how it still affects her day to day. She still has times where she vomits uncontrollably. She has episodes of diarrhea. She faints and has to wear a heart monitor. As she summed up, "My body is just different than it used to be." So the next example is about a case of an ectopic pregnancy, which the animation is correct for. Several states have specified that an ectopic pregnancy is an exception to their abortion ban. This does not mean that patients are actually receiving timely care. So again, an ectopic pregnancy is implantation outside of the uterus. It can never be viable, and it becomes increasingly dangerous as it continues. So this woman that I interviewed, she was 37-year-old and identified as Hispanic. She'd gone to the ER multiple times with pain and spotting. And very early on, she talked about how they kept talking about it was a possible ectopic, but they would just say possible, and they would never say it was an ectopic. So she was monitored from about 6 weeks of pregnancy until 14 weeks, going in regularly in order to get blood draws, which is one way that whether or not it's an ectopic pregnancy is measured. At 14 weeks, she developed a fever of 104.6. She was alone at home and she lost consciousness. She talks about, she believes she was probably in and out of consciousness for at least 4 hours. Her mother happened to come over, which was not, I mean, that was not a standard thing, and found her unconscious and rushed her to the ER. Her fallopian tube had ruptured and she was bleeding internally. She had sepsis and she was in the ICU for almost 2 weeks. So 10 months later, at the time of our interview, she was still struggling. Oh, I went too far. That's why. Okay, there we go. Sorry if I had these out of order. She was still struggling. And as she says here, she had to work hard to get her health back. So she had to do rehabilitation. And she still feels like, especially for her breathing, has not recovered. If I try to take a deep breath and hold it, I can't. If I yawn or laugh too hard, I go into a coughing fit. And she was somebody who had been very, very outdoorsy. So this felt especially stark, this difference. So across the interviews, respondents reported getting warnings from their physicians that continuing the pregnancy could have physical health risks, but they had incomplete information. They didn't know what that meant. And it could be that at the time, the doctors didn't know either, right? Like PPROM, ectopic pregnancies, had always been treated. Nobody knew what would happen if they were allowed to progress. But now they know, right? Now they know. Only bad things happen. I'm going to switch now to talking about some of the mental and emotional health effects that lingered well after people came home from healthcare. So many interviewees described their experience as emotionally twofold. And some even use the language of trauma, describing this as two separate traumas. So one part was the pregnancy loss, which most of the people I interviewed mourned deeply. For most of the people I interviewed, this was a very wanted pregnancy. And so losing it was something that they grieved. The other source of the emotional complexity was their experience of being denied care or having care delayed. And this was something that many described as traumatic, but it compelled a different kind of processing after the fact. So for example, one woman whose fetus had a fatal health issue, she had to drive 13 hours to get abortion care in a neighboring state. And she talked about her experience as, quote, essentially two separate events in my brain. She talked about the loss of her baby. We grieve the loss of our baby, but we're recovering from the trauma of the events that happened. And so she talked about doing grieving and going through this experience. But we're still working through the trauma of what happened when I was denied care and still kind of mourning the anger phase of it. The actual abortion could not have been prevented. That was how it is. That's what happened. We had to get one. But the events that happened to make us leave the state, all of that could have been completely avoided. Another interviewee described how 2.5 years after experiencing PPROM, I think that's the one thing I really want to get across to people, is that losing her was hard enough, but it was navigating the fact that a state entity told me that I didn't matter is what really compounded the pain. And it's that pain that explodes your life. Another emotional complication that was caused by the delayed and denied care that interviewees described was what I've called interrupted grief. So first, I'm going to offer a couple quotes. So this was a woman who was 27 years old at the time of her pregnancy. She had PPROM at 20 weeks. And she was sent home and told to come back whenever she went into labor. She talked about that time as just deeply, deeply traumatic. It was grieving and knowing that we couldn't grieve yet. And that creates this, I mean, it's really weird mental conundrum because you're in a position where you're trying to say goodbye, but you can't because she's inside of you. She's still very much a part of me. She's still very much taking all the nutrition that I'm taking in. Another woman talked about how, and she was somebody who had a fatal fetal health issue and then was required because she couldn't afford to leave the state for care to continue her pregnancy. And she ultimately went into labor and delivered at 32 weeks. She said, I had to turn off my humanity to keep sane. I just had to. I was so shut down. It was more all brain and no heart. So this delay in being able to grieve created uneasiness and even guilt among interviewees. Some reported feeling that they'd failed their babies by being unable to end their pregnancies sooner, which compounded the complexity of the grief they experienced. They talked about their doctors trying to help them, prescribing antidepressants, for example, referring them to psychiatrists and therapists. And this was of great help to some respondents. But for others, especially those without comprehensive insurance who were limited in their ability to utilize these resources, the available support was inadequate. And as with the ongoing physical health effects, the mental and emotional trauma respondents described was, at least in part, avoidable and experienced only because of these post-ops restrictive laws. So lastly, I want to look at some of the impacts on future fertility. So most of the women I interviewed, this experience explicitly affected their future fertility. In a handful of cases, their care left them with reduced fertility. So there were, for example, the interviewee who had a ruptured fallopian tube now cannot become pregnant through an egg moving through that fallopian tube. This is just a measurable reduction of fertility. So in addition to these physical consequences that had impacts on their fertility, many also talked about how their experience had changed their fertility desires. So about 20 had an immediate pregnancy post-loss. And I'm saying about because I haven't really sorted through for the people who had more than one pregnancy, how I want to consider that when that subsequent pregnancy also had a complication. For most people who had a subsequent pregnancy, I don't know how to get that to go away. Sorry. Okay, go away on its own. For most people, they described that subsequent pregnancy as terrifying, and also healing for those whose pregnancy was healthy and resulted in a living baby. It bears mentioning that many of these pregnancies would not have been able to happen if it were not for the abortion care that those respondents were able to get. So that they had to continue their pregnancies until they went to labor or the fetal heartbeat had ceased, they would not have been able to have these pregnancies, right? There was just the time shift. And some of them were really cognizant of that, recognizing the way that their subsequent living child was both sort of a miracle and it could only exist because of the care that they had been able to receive. So that was the immediate response by around 20 folks. But longer term, the majority reported that they planned to reduce their future fertility because of this experience. So for example, one woman who had a fatal fetal diagnosis who had to travel out of state for abortion care said, "As much as I want another child, I don't feel safe having one until there's more clarity." Another who had had 2 pregnancies affected by restrictions, one that had a fatal fetal health issue for which she had to travel out of state, and one with a maternal health issue for which she received in-state care. She said, "I don't think that I want to get pregnant as long as either we live in the state or as long as the state has these laws. It just makes me too nervous. Like, what if something goes wrong and I go into septic shock or something and they refuse to do anything about it because they can't?" Another person who also had 2 pregnancies affected by the restrictions, again, one with a fatal fetal health diagnosis for which she traveled out of state, and one with a maternal health issue for which she received in-state care. She said, "I'm honestly scared to have sex. I don't want to get pregnant. I don't want to die." Some respondents reported that they had had their tubes tied or their husbands had had a vasectomy to ensure no future pregnancies. And these were different choices, they said, than they would have made had they not had the traumatic pregnancy experience. A handful reported, however, something different. There were some who said that they felt unsure. So one woman whose pregnancy had a fatal fetal anomaly and she traveled out of state for care said, "Right now, with the laws the way they are and our age and our risk factors," she was 33, and everything, it does give us pause. And we really can't say right now one way or another, right? So there was a sort of a shift from beforehand where she felt very confident that they would have more children. Now she wasn't sure. And there were a few who insisted that they were not and would not change their long-held future fertility plans because of these laws. They refused to let the state dictate their family composition. So one woman who had a fatal fetal anomaly for which she traveled out of state to get care said, "I understand the risk that I put myself in being in the state, but I'm not willing to let them win. So I'll decide when I want to finish my childbearing in this state. Even though it seems like these are sort of divergent responses, right? Reduction, insistence, or even being immature. What they hold in common is that all of these respondents were thinking about and articulated their future fertility plans in relation to the state and the law. So their choices and plans were in conversation with this abortion ban. The state was taking part in their family decision making, even as the abortion ban wasn't actually talking back to them. And in orienting their fertility plans this way, I think what these women were doing is attempting to reassert bodily autonomy in the face of laws that would deny them it. In some ways, this was a form of resistance across the ways that they had shifted their future fertility plans. So the delayed care and denials caused by post-ops restrictive laws are a health issue. And it's a health issue that isn't resolved when the person is finally able to receive care. The delays matter. There's lingering physical recovery, there's reduced fertility, there are these long-running mental and emotional impacts. These negative impacts are also clearly a policy issue. They demonstrate the unintended consequences of blunt policy on healthcare, or even more specifically, reproductive healthcare, and of the fallacy that limiting abortion based on pregnancy duration is ever safe medical practice. The law is typically black and white, but medicine is gray, and the policy has to be written to acknowledge and allow for physician discretion. I think this is also a gender equity issue. It's women and others with the capacity for pregnancy who are experiencing the physical harms of these policies, and the mental and emotional harms too are gendered. This is not to say that there are no harms on their families, their partners, their parents, their existing children, but the particular mental health impacts that I find have a gendered valence. They're in part constructed in terms of maternal responsibility and failure, right? So this idea of being responsible to protect one's baby, both a failure to do so when one's own body and also a failure to protect the baby from the intrusion of these hurtful laws. What now? In terms of policy solutions, there has been a move in some states to tease out and make more explicit these medical exceptions. We'll see if that really makes any impact. It won't resolve the bigger issue. And so one of the key things that needs to change is the level of evidence that's needed in order to establish a life exception, a health exception, and probably eliminating many of the penalties for these violations. Even better would be eliminating these policies, right? That they really don't have a way of working in practice that will keep everybody safe. Policy solutions are maybe unlikely, at least in the near term. And so I think there's also a response, an opportunity for a systems response. In the Care Post Roe study, what we found is that a lot of individual providers were able to advocate for their patients, often using personal networks, both within their healthcare systems or even across state lines and other systems. And this was really useful for their individual patients, but it's not a workable, scalable solution. So there does need to be like an organized response by the healthcare system. I also think that there's an opportunity for values clarification by healthcare providers. So the women I interviewed were nearly unanimous, insisting that the problem was the policy, the laws, not their doctors. And it is true that these policies tie the hands of healthcare professionals and fundamentally undermine their willingness to provide emergency obstetrical care. It doesn't undermine their ability to provide this care, nor does it change their knowledge of the harms that come from delaying or denying care. So it's reasonable that they would decline to provide, but it's also untested legally. Both individually and as a sector, healthcare professionals need to examine their reaction to these bans. Are they complying in advance? Is this a case for civil disobedience? What is certain is that these women continue to negotiate what it means to have had their reproductive health care delayed and denied. And they are only a subset of the people these bans have affected to date and continue to affect. So this makes abortion policy a crucial area for ongoing research, interventions, and advocacy. Thank you.
So we're going to do a question in the room and then a question online. If you're on Zoom and you have a question, please put it in the Q&A and Sarah is going to moderate that from here. Yeah. And then.
Does anyone in the room have a Yeah, I do. Thank you very much. So you're doing all of these studies, right? And getting evidence. But what about the people who support these bans? Are they doing studies and evidence? And when you read what they're saying these work. So and people aren't refuting the fact that they work, at least in their world. So is your matching evidence being matched on the other side, or that evidence is not going to be relevant here because it's a moral issue as opposed to an evidence issue?
So that's a great question. I mean, thinking about how people who are proponents of these bans and how and whether they've examined their effects. I'd say, I think many of them are frustrated that they haven't worked as intended, meaning they are continuing to pursue efforts to say, make telehealth illegal, right? So it's not as though these bans have actually resolved, I don't think anyone really believed when the Dobbs decision came out and the Supreme Court claimed that this would resolve this tense issue. Like it didn't do anything like that. So I do think that the proponents of these bans are frustrated that it hasn't worked as well as they want it to. I don't think that they have. So there are a few cases where there were individual legislators who have seen the implementation, particularly in terms of the like PPROM or ectopics, who've gone back in and tried to clarify. And so to carve out, no, these are cases where physicians should not be slowed down or prevented. So there have been a few instances of that, of sort of a revision of the way that they think that the law should be written. But there's also been, like, for example, in Texas, where they just said, no, the doctor should have provided care, right? It's a little bit of a sort of passing the buck, right? Like, no, this wasn't actually a flaw in the law. This is a flaw in the doctors. And so you should sue them for malpractice. And then we've also seen, I think one of the things that has also been the case is a sort of ignoring or denying that these are true cases. So the other move by proponents of these bans has been to assert things like these stories are made up, these are paid actors. And so this is as a sort of social movement tactic, the idea of that's not actually engaging in people in a sort of reality-based way. In terms of actual research that is being done, there's, as far as I know, like there are a number of professional organizations that identify as pro-life who've insisted that there is never a need for abortion. And I don't know that they've engaged in any research trying to suggest that actually these were good outcomes.
Thanks, Katrina. We have a question online from Janet Kaufman, thanking you for your wonderful talk. And she's curious to get your thoughts on what explains the increase in medication abortions since the Dobbs decision.
Is that what has been the increase, or what
explains the increase? And
yeah, we'd already been seeing, even before Dobbs, the proportion of abortions that were completed through medication as opposed to procedural had been going up. And so in some ways, this is probably a trend that already was sort of on the rise. And then one of the big things that happened after Dobbs is there was a separating, so prior to Dobbs, for a clinic-based abortion, whether it was medication or procedural, the price was typically the same. And much of the logic behind that by providers was that they didn't want to coerce or incentivize people to have a certain type of care because of cost. But we can also imagine that the costs are very different between what a procedural abortion and handing out some pills. So the rise of telehealth and other ways that people could have abortion pills mailed to their house, you saw then a divergence in the cost. And so I imagine that that's also a contributor to that the increase in a preference for medication abortion. There's also a number of aspects of medication abortion. Some people find it to be more private. They find it to be more natural. Like these are there are ways in which there are just some preferences that people have had, and it may be that it may also be a product of avoiding the experience of needing to go in person to a clinic, where there may be targeting by protesters. There may be travel costs. So I think there are a number of factors there. Some of them are keyed into Dobbs, and some were ones that were already sort of on their way.
And I would just add to that, COVID also came through at about the same time. And I think that is really the biggest impact on changing some of the regulations around needing to have an in-person visit to access abortion pills. And once that was separated, then access increased in many ways.
Yes, that's an excellent point. That with COVID, prior to COVID, there had been a number of restrictions by the FDA on how medication abortion, specifically mifepristone, the first pill that's typically used in the United States, how that could be dispensed. And with COVID and concerns around in-person, there was first a sort of test loosening, and then that became policy, and that really changed the ability to access medication abortion.
I think we are at time. Thank you again so much. Katrina.
Thank you.